Keshav Sharma from third course, specifically from the group 301A. So today I will tell you about the topic ulcerative colitis. So let's begin with it. So ulcerative colitis, it is a chronic inflammatory disease limited to the colon and the rectum. So colon and the rectum. So you can say it is the disease of your lower GIT tract. Am I right? Yeah. So it is because of continuous mucosal inflammation. You will see the continuous mucosal inflammation. It will start in the rectum and extends proximally. So in the most of the cases, it starts in the rectum part and extends proximally, which means upper side. So it can be autoimmune or relapsing remitting course. So if it is happening again and again, it can be a serious problem. So now, etiology and the risk factors. Exact causes are unknown. Okay, so we can call it idiopathic, not specifically, because we know some factors like genetic predisposition, which is including gene HLA-B27, immune dysregulation, environmental triggers, Western diet, smoking cessation. Western diet, we all know, it consists a lot of breads, so it can cause this type of inflammatory disease. And also smoking cessation, it is some kind of different aspect we are seeing here. So we know that smoking causes many problems, but stopping of the smoking can cause some problems? Yes, it can cause ulcerative colitis. Many reasons can be. It can, first of all, it can be the change in the flora, or you can say the microbes activity inside our gut health, and second one is the anti-inflammatory effect of the nicotine. So coming to the next point, gut microbial imbalance. Now pathophysiology. Let's go for the pathophysiology. So immune dysregulation causes mucosal inflammation, very common, we all know that. Cytokine release, TNF alpha, interleukin 1 and interleukin 6. We can see ulcers, bleeding, crypt abscesses, always involve rectum, continuous spread proximally. So it will always include rectum part. If someone is suffering from the ulcerative colitis, the rectum has to be in it and it has to be suffered. Now let's go for the clinical features. We can see the bloody diarrhea will be there, LLQ, lower abdominal pain will be there, little lower quadrant, tenesmus urgency we can see, fever, weight loss and the fatigue. Well, however, it is common in the all of the GI disease, but yeah, we can say fever, weight loss and fatigue we can say. Yeah. So extraintestinal manifestation. So other than the intestine, which parts it is affecting? Let's see about it. Musculoskeletal, arthritis, ankylosing spondylitis. In the eyes, it will cause uveitis, episcleritis. In skin, it will cause erythema nodosum, pyoderma gangrenosum. And in hepatobiliary, it will cause PSC. Now, investigations. How we can see in our lab results or in our reports. So, in labs, we can see increase of ESR and CRP level. ESR means erythrocyte sedimentation rate, and CRP is a test which is commonly we do for the checking of inflammation inside the body, which is C-reactive protein. We can see anemia and also P-ANCA test will be positive. Now, in the colonoscopy, we can see continuous inflammation, friable mucosa, and by the biopsy, we can see the crypt abscess and goblet cell loss. Now coming to the disease extent, like what will happen next? Proctitis, it will occur in the rectum only. Left-sided colitis, up to the splenic flexure, In the pancolitis, entire colon will be affected. This is the main part. After, symptom will be the worsen with increasing extent. As the extent will increase, the symptom will worsen. There will be more bleeding, there will be more fat loss and other thing as well. So management, how we can treat it? So if it is occurring in the mild to moderate range, we can give 5-ASA, mesalamine. We can do topical or oral corticosteroid because the rectal opening we can reach up to the rectal opening and we can apply some topical corticosteroids. But if it comes to the moderate and severe, we have to go for the systematic steroids. We have to go for the immunomodulator, where the example is azathioprine. We can go for the biologics. Now let's go for the complications. What are the complications that we can see? In the acute one, we can see toxic megacolon, perforation and hemorrhage. In chronic, we can see colorectal cancer and PSC. In surveillance colonoscopy, every 1-2 year after 8 year. So till 8 year we have to do colonoscopy again and again to see if the things are going well even after the treatment. Now, differential diagnosis. So differential diagnosis can be of multiple in this condition. First one is the Crohn's disease, skip lesions and transmural. So these are the points why they are different. So infectious colitis, stool culture and acute onset, ischemic colitis, elderly and sudden pain, IBS, normal investigations. So summary, let's go for the summary. Chronic inflammation of colon, continuous mucosal involvement, diagnosed with the colonoscopy and biopsy, treated with the 5-ASA steroid biologics, 5-ASA only if it is in the acute state, colorectal cancer risk even after 8 years. So we have to do the colonoscopy after 1 to 2 years again and again. So here all about the ulcerative colitis that I have to tell you guys. And if you want this PDF, you can comment down below and the teacher will provide you this PDF. Thank you.